Good morning, everyone. Well done for making it in at 9 o'clock. So first session today is Advances in Robotic Pancreatic Surgery. It's a great pleasure to be joined on the panel by Ricky Bogle from the Royal Marsden, Professor Taylor from Belfast, and Gab Marangoni from Coventry. And we've got what looks like an exceptional lineup of UK and international talks today. So we're starting with Mr. Arshad. Ali is from our neighbouring unit in Southampton and is going to talk to us about from scratch to success, launching and excelling in a robotic HPB surgery programme.
Good morning, everybody. Thanks very much, Tim, for the introduction, and thank you for the invitation from Jawad. Thank you very much. Okay, take two. We'll start again. Okay. Right. So the first thing to say, we weren't quite starting from scratch. So we're a large unit, catchment of nearly 4 million for pancreatic surgery, certainly. And before the robotic program got going, we probably had the largest UK laparoscopic HPB series, mainly due to colleagues such as Mo Abu Hilal, that many people will know, Neil Pearce, who then trained the rest of the unit. We were doing about 40% of our pancreatic resections laparoscopically, which includes a laparoscopic Whipple's program, which has since stopped. And about half of the liver resections were being done laparoscopically, so a lot of laparoscopic experience in the unit. There was one Da Vinci platform, which was solely for the use of urology and nothing else. So that was our sort of starting point. So what happened then? Well, COVID happened, and then during COVID, there was lots of discussions about expanding the robotic program. And it all happened in a very haphazard way. I'd love to tell you that it was all planned and everybody had, structure and business plans for who was going to go on the robot, but it just didn't happen like that at all. We acquired an XI platform. The trust agreed to buy one. Half the prostate work was outsourced, which freed up some more capacity. And there was a rapid trust-wide robotic expansion. And I've put the cowboys in there because it really was a Wild West land grab. And some specialities did quite well. Others were not so lucky, and we were just really lucky in that what was offered matched up what we could take up, and that we are where we are because of that. So there was no structure to it whatsoever. Okay. Business case bids were put in by various specialities to be allowed to start on the robotic platform. And our business case happened to be one that was at a relatively late stage of evolution when the platform landed. So all particularly just serendipitous, really. And then some decisions to be made. So we had some colleagues like Lancelot Spratt-like colleagues who said, the robot is dangerous. It's no benefit at all in HPB. We can see why it's good for urology, but it has no place in our speciality. But to be fair to them, they were not obstructive. They just weren't particularly supportive. And then we decided that we were going to have two surgeons, and we were going to start in a stepwise fashion. Make sure we had enough volume for those two surgeons who were going to work together for the first 6 to 12 months. And the capacity that we were offered happened to match the list that we did anyway. So it all worked quite well. We followed Jawad's model of step-up training, level 1, 2, 3. We opted for an SFA, so surgical first assistant tableside model. I'll talk about that a bit later. And we ended up with 6 lists a month. So a list every Thursday, which is mine, and a list every other Tuesday, which is a 3-session list for my colleague. And we started in July 22. One of the problems we had is that our unit data for open surgeries is pretty good. So this was one of my colleagues, one of our registrars who's put this together. So this was my first 100 cases as a consultant, having trained in Leicester and then a year in Birmingham, and then going straight into a consultant job after that. This was the data that we were going to be compared against for our robotic program. So if it was not as good as this, if it was in any way inferior, then we were going to have a problem. So the benchmark, I'm a slow surgeon. I'm really not very quick, as you can see, but the data was pretty good. So we went to Utrecht. We took the team. So myself and Zaid. We've got the pointer kind of works. There you go. We got Ron, who's our surgical first assistant, and we got Arlene, who's our team leader. And Ron is the robotic guru, so he only does robotics. He knows the platform inside out. He knows how to sort out clashes. He can staple. He can clip. He is like having a colleague at the table, only better because he knows the robot so well. So we couldn't really do it without him. That's the team. You'll see Joad at the back. That's after our, I think, third or fourth distal panc. So we're really pleased with ourselves, but really we were only just starting. So that's what we've been up to. So we've got a slightly different model to some of our colleagues in other units, in that we haven't really, after the initial training series of cholecystectomy, we haven't really done very many at all. We've done really morbidly obese patients. We've done completion choles, or difficult ones, but the sort of more standard ones, even the sort of hot ones or difficult ones, we just haven't really done them because we just haven't got capacity. We've concentrated really on level 2s and level 3s, so up to nearly 300 robotic cases, of which about 80 to 85% are level 2 and level 3. 31 Whipples, 85 distal, so about 120 pancreatic resections and 88 livers. So this is a graph. It shows the open cases at the top in blue. The laparoscopic cases are the orange ones, and the green ones are the robotics. And that's just numbers. So there was always going to be a crossover where laparoscopic went below robotic, and that happened pretty early on, really in the first 6 months of our program. There's a small amount of laparoscopic liver going on, usually some minor wedges from our non-robotic colleagues, but really the majority of our minimally invasive surgery is now robotic. And then just some of our data. So you'll be familiar with these. This is the quantifying the impact projects that Intuitive love. They're good because they show real life clinical data. Our own execs don't believe the cost numbers, so we've had to cross validate them internally for the business plan for the next case, because they really do look at every pound, unfortunately. So I take the sort of financial things with a pinch of salt, but the clinical stuff is real. So this is major liver resection. We did this about 6 to 8 months ago, so we've done quite a few more since then. But a 2-day length of saving and length of stay over open for robotic. A day less on HDU, no conversions, no blood transfusions, similar levels of complications, slightly higher readmissions, but half the blood loss. So really nice data for major opens. This is minor livers. The minor livers are really comparable with laparoscopic, other than that the conversion rate is much lower. We've seen that from our colleagues already. So I think we're saying the same message. You're much less likely to convert a robotic liver. The complication rate is half of that of laparoscopic and far lower than open. The distal panc, so I still think that distal panc is one of the most morbid operations we do, unfortunately. There isn't really a way around that. This is comparing robotic with lap, and really it's very similar. The only thing I would say is our grade 3 complications are half with the robot. I don't really know why. That's just an observation. But we're really sort of, the Achilles heel is the readmissions, and nearly a third of our patients are coming back. It's usually something to do with the drain. The drain was a little bit painful, or the drain leaked a bit, and they end up coming back for a couple of hours. But that's our experience, probably similar to everyone else's. And the Whipple stuff's been really interesting. So we've done 31 Whipples. Joad proctored our first series, and I wanted to compare. So the robotic is the blue bar. The green bar is the pooled open surgery data for our whole unit. Okay, and then the orange is the data that Babik did for my first 100 cases. So I wanted our bar to be really self-critical and set our bar really high. So in terms of post-operative pancreatic fistula, this is B's and C's, and I've excluded all the biochemical leaks. This is literally just people that need have clinically significant pancreatic leak. 6% in the robotic arm. It's quite a bit higher in the open for the unit. It's about the same as my own data. The length of stay is better for robotic, not by a huge amount. And I really do think that the gains for robotic Whipples are probably fairly subtle. I think anyone who claims that robotic Whipples is amazingly better than open Whipples. It's quite difficult to believe that, but I think it is better, honestly. The HD length of stay is less. We've had no reoperations. Readmissions are the same. We've had no mortality. We've had no bile leak. We've had no chyle leak. The grade 3 complications we've noted were significantly lower. On to training. So that's Ahmed. I think he's in the audience. So I hope he's in the audience. He is. So this is Ahmed and myself doing a spleen-preserving distal pancreatectomy on Thursday. So Ahmed's on the left console, I'm on the right. And really the dual console, as many people will have experienced already, is fantastic for training. And we follow the similar model to everyone else. So they do online modules, they do the course, they do the sim, they do some bedside, we insist, before they get on the console. At least 10 cases bedside. This is Ahmed's logbook over 6 months. So he's been involved in 45 cases. He's not done all of those 23, so he's not done 4 Whipples, but he's done bits of those. So he's done some duodenal cockerization, he's done the coles, he's done some liver wedges, he's done quite a few of the spleen bit and the distal stump for the distal pancreatectomies. And then he's done a load of tableside, he's done lots of courses, he's done a load of simulation. So hopefully getting a good experience as a fellow. And then, yeah, what would I say to somebody starting out? Don't be haphazard like we were. So have a really clear structure. Have a real clear structure in your hospital for who is going to get robotic access and why those lists are set up as they are. It needs to be clear, it needs to be fair, and there's a lot of politics and there's a lot of sort of heartache when people are talking about robotic capacity, and you need to try and avoid that. Please come and visit us. We're not an intuitive observation centre. We haven't jumped through the hoops yet, but anyone can come whenever they like, and that's fine with us. Have a clear plan for yourself and your unit. Please take your colleagues with you, especially the non-robotic ones. Make sure that they're supportive and they'll give you cases. I'd strongly advise that you have a dual consultant model. I think if you're doing this on your own, it'd be extremely lonely. And then finally, we're going to advertise our fellowship for October shortly. So applications are invited. Thank you.